you're all leaders sitting here. You're all leaders in different ways, but very few of you are managers, okay? So, or would you say that you're a manager? Maybe some of you are. So what is a leader and what's a manager and what's the difference?
I can say a leader is a first creator.
Uh-huh.
Then a manager is a second creator.
Okay.
By means of the leader is the person which is leading the people, which is doing something for the first time.
Uh-huh.
Then the management, he must keep whatever is being done. He must manage whatever is being done.
Okay. So we're going to have this roving mic around. Anyone else? Any other ideas? Yep. Okay, Anneline's off duty now.
So my idea for leader is someone who cultivates, initiative, creativity, leads, for example, it's somebody who facilitates growth in a group, move things forward.
And so what's a manager?
A manager is someone. A manager? What? I don't know what a manager is. For an organization, yes, just organizing.
Okay. All right.
Yeah, I don't know.
Okay. Catherine?
Hello. To me, a manager is the one who manages the day-to-day programs of that certain organization. And a leader, I can take it as a governor, a policy makers.
Okay. Uh-huh.
That's
Okay,
how
that's perhaps
I
understand.
define it.
There's Nozuko at the back.
Oh, thank you. I think a leader is someone like a visionary. A manager is someone who takes initiative, who is creative, and doesn't run after people.
Okay.
That's a manager.
Okay. All right. Yeah?
I think like a cool analogy that I heard about leaders and managers is that if there's a wall, you know that there's the problem. The wall is the problem. The leader comes up with the vision. They'll say, okay, the first person to climb the ladder to the top of that problem, tell everyone how to climb it.
Okay. All right. So you've all said things which are correct, actually. So maybe that last analogy is the best one to think about it, because here we have an NHI coming, we have a health system that's coming. A leader thinks about what's on the other side of the wall. What could we create? And what are the things that would help us get there? And then the manager is the one, as you say, goes to Builders Warehouse, plans the campaign, makes sure people are employed, they do their job, holds people accountable, makes sure things are efficient. So you can also be a leader, you can have vision if you're a manager, but they're not always the same. And the problem in South Africa is we have a lot of managers who stick to the rules, who keep people to the rules. We don't have very good leaders who are able to kind of think what's on the other side of the wall. And sometimes we have managers who are actually very bad at what they do. And they're bad in different ways. They waste money, they might be corrupt, they're not efficient, they don't hold people to account, they aren't accountable themselves. Not everyone, but that's the problem. So, what do you think our minister is?
He's a leader.
He's a leader because he's got a vision somewhere. He's actually a very bad manager. Okay? Doesn't hold people to account. Things go wrong. What happened? Okay. So in South Africa, what's the case? I don't know if you can see that picture. It's actually from the report. Can you see what's going on there?
I think the mic. It's a bucky.
It's a backing?
Yeah, people at the back.
These people are?
Minor.
No, that's mine. It's a patient.
Construction.
It's a wheelchair. It's a wheelchair. And that's the ambulance in the Eastern Cape. That's how patients are getting to hospital. It's from the Section 27 report on ambulance services in the Eastern Cape. And we know the Eastern Cape has a history where the previous MEC, about 2 MECs or 3 MECs ago, had his private company running ambulance services for the Eastern Cape. The net result
is we have ambulance services that are totally they're basically run into the ground, so people are having to use private transport to transport patients. And that's a problem of leadership, because that was the MEC for Health. There was an accusation made against him, and he was cleared, because it was said, no, there was no corruption. But he was the MEC for Health running a business which was contracted with government, and the consequence is we don't have public sector ambulances functioning in the Eastern Cape. So we've had a number of provinces under administration. So that means basically if you're a health department and you're not doing your job or you're incompetent, the national department, government puts you under administration, so they make sure that bills are paid, staff get their salaries, things like that. We've had it a number of provinces over the last few years under administration. We have unfilled posts, so David spoke about that. TAC did a survey in 2018. They estimate about 37,000 posts in South Africa unfilled. So our comrade Lesego waits for a post, and he's get told that there's no post, there's no funding. Well, that's a management issue. So there are posts, but there's no money for it. Why there's no money for it? You would have to understand how the planning process works and who's dropped the ball. Somebody's dropped the ball on that. And of course, there's a bias in favor of urban areas. We've heard about this question. So community service posts tend to be allocated in urban areas, and they tend to be filled in urban areas and not in rural areas. We've had the problem of drug stockouts. There's a whole campaign by Section 27 and TAC. Eastern Cape Ambulance Services collapsing. The National Health Laboratory Service nearly collapsed because some of the provinces were not paying their bills. So Gauteng province stopped paying their bills because they ran out of money. So how's the National Health Laboratory Service going to function if they don't have money to pay their staff? So it's incredible that one government department doesn't pay its bills to another government department, but that is what happened. Oncology services, so cancer treatment, you remember in KwaZulu-Natal, basically it collapsed because there was a machinery that wasn't maintained for years. Specialists were employed, they were getting salaries, but they couldn't do their job because the equipment wasn't working. So that's a problem of management, knowing that you have to have the resources so people can do their job. This is last year headline from the Citizen. Gauteng leaves 600 million unspent. Okay, and this is the same department that, load shedding. Uh-huh. Okay, all right. Okay.
Load shedding can be very difficult.
Very specific load shedding, just in this room. No.
So we would need your card.
Eh?
I think you would need your card.
No, that's just for switching this box on. It's the electricity that's gone off.
But the electricity in the hall is on.
Will you go to the security in front? So I tell you what, should we carry on without the slides? Otherwise we'll be very late. But I will need my computer. On like this. Okay, so I wanted to talk about Esidimeni. Okay, you know what happened at Esidimeni. Okay, anyone want to Just explain how you understand what happened with Esidimeni, Life Esidimeni in Gauteng. Anyone? Catherine? One second. Sorry, use the. Apparently the mic is working, if nothing else.
Okay. Yeah, patients were located to the NGOs that were not accredited,
Yeah.
and it ended up being abused, and
Yeah.
most
So what kind of
died.
patients were these?
The mental patients.
So there were patients with long-term psychiatric disability,
Yes.
cognitive impairment, and some other psychological disorders. They were there for a long time, being cared for in Life
In
Esidimeni,
Life Esidimeni, yes.
and they were shipped out.
They were shipped out to the NGOs.
But there the cat was on. They said it was
And even on top it's on.
hours.
Are you noticing that you are continuing?
We are we're actually continuing without the
Okay.
thing, but if it comes on, it comes on.
It's going to take another 3 hours. They're working and they can't turn the electricity back on, so we can move to another room, PG1, with electricity, or we can wait here.
We can work here.
We can work here, I think. Mel, can you work here without PowerPoint? Mel, can you do your session afterwards without PowerPoint?
Well, I can do for you. I mean, I've got it on my computer.
So we'll do it like that.
Okay, so I'll just tell Celeste before we carry on. So we don't change rooms.
Do you want to change rooms?
No,
No.
we'll take it.
Okay. So we were talking about Esidimeni. So these were long-term psychiatric patients who were shipped out to NGOs. And then what happened?
And most they've died. About 42 died in the process.
You're 177 at least.
Yeah.
We don't know exactly
Oh,
the
yeah.
number.
And some were not accounted for, and
Yeah.
the MEC, there was a negligence through the MEC, because she was a politician, she was not a doctor.
Yeah.
That is why she didn't think before she gave that contract to the SCDM, to those NGO. So it ended up people dying because of negligence.
Yeah.
People they were starving, but money was coming into the organization. But people, they starve people. The real thing, they starve people. They don't care about them, you know.
So this
it
was
ended up with the help of Section 27. People were compensated for the death of their loved ones.
So there was an inquiry afterwards, and then
Yeah,
there was
there
a judicial process, and the Department of Health compensated people. But why did the department do it in the first place?
What did they?
Why did they do it in the first place? Saving money. That was it.
We are trying to save money.
They were trying to save money. They ended up spending a lot more money than they
and
saved,
they
right?
ended up,
Okay, so the MEC said, no, this Life Esidimeni as a facility is costing us too much money. We must find a cheaper way. Let's find a cheaper way of doing this.
and the cheaper way was
The cheaper way was finding NGOs, which some of which weren't really NGOs. They were just organizations that were set up in order to get the money. And they weren't competent to manage to care for people. They didn't have staff who had the right skills. A lot of the people who died of starvation, died of bed sores, died of basic, things that would not have happened if they had basic care. So what does it say about leadership and management there? Anyone? What does it say to us? Apparently that's still working. Yeah.
I think for me, if the decisions that your leaders make are a monetary basis, a cost-cutting measure, it reflects leaders that don't really think about they don't care about the population.
Yeah.
So to me, that's concerning. It's who are our leaders, who are they serving, and are they the right people to be in those positions that will make decisions for the interests of the population.
So if you treat people as objects, I mean, that's really what they were doing, cost objects. They didn't treat them as patients, as people with dignity, with rights. They treated them as a cost center. And we can manage them more cheaply if we do it like that.
And the second thing is when you have a leader who is somebody who's in the field of education, leading as an MEC in health, making decisions around a very specialized set of care for mental illness, is she the right person to be making those decisions?
Okay, so that's the skills of our leaders being appropriate to what we need. Okay. So Tinashe has pointed out the cadre deployment issue. So many managers actually are appointed because of their relationships with political leaders who don't necessarily have the skills. We've seen that. I mean, we see this is a terrible consequence of that.
Yeah, I don't know in the issue of Esidimeni, is the minister more to be blamed than the HOD?
Yeah.
Because the HOD is a doctor, school together. So there's the other question maybe we should be asking, because the head of department, that one is just a political oversight.
Yeah.
But who was doing it? I think the head of department, rather than saying because the head of department will tip the MEC, then the MEC will make some political decisions. Okay. So maybe we should separate the levels, who was responsible for what.
Yeah, so you won't have noticed, but when you come into this faculty, there's a piece of art on the left-hand side, and it's a piece of art about Steve Biko. And you will all remember there were doctors who were treating Steve Biko while he was detained, and they got an instruction from the police, and they didn't say, no, we're not going to follow what you're going to do. They said, okay, we'll sign off a certificate that said there's nothing wrong with him, and you know that he died of a head injury because of torture by the police. Well, the head of health here got an instruction from the MEC. Could he have said that, or could he have said that? And he said, okay, MEC, we're going to proceed with this. So you know that he was at the hearing, and he apologized, but he never really explained why he chose to do what the MEC told him as opposed to doing what was right for the patients and the population. Anything else that you want to add about this? Yeah? Yeah?
So I think when things like this happen, the people who are involved are usually not all bad people. Some of them are quite good people. But when it comes to certain situations, they can do bad things. Good people can do bad things if the environment is like that. And it happens if they're not critical thinkers, if they're not critically aware of what they're being asked to do or what they're being ordered to do and what the impact is. And particularly if they're not critically aware of the humanity of the people they are supposed to be serving. So I think, it happens easily that a good person can do bad things if they don't think critically about what they're doing.
Okay. And I think Louis' point's also the environment. So we need an environment for management and leadership that puts values like equity, like human rights first, and doesn't exclude those things from what we do. Okay, so the points I was going to put up here were about austerity. So this was driven because the Gauteng Health Department wanted to save money. All of our provinces talk about austerity. We don't have money, we can't fill posts. So this is the consequence of simply saying, okay, I have to save money because I work for the health department. There's no question about saying, well, do we have enough money allocated for what we need? Do we have enough money for the posts that we need, for the need of the population? Second question, the point about political interference. So Lesego's right, the MEC, they're a political appointment, and Shanaz is saying, well, maybe a MEC who has an education background won't understand it. But that MEC was able to interfere very directly in the running of the department. So that's a question about the kind of leadership and management and governance systems we have. And then we've spoken about the human rights issues. So the problem is, if we introduce the NHI, you've seen how complicated it is. We are going to need managers and leaders who really are quite skilled. And what we have is a patchwork of leaders and managers in the country. We have some very good health managers and health leaders, but we have others who are not very good. And so we're going to put up the system which requires people to negotiate with the private sector. So you remember what David said, in the rural areas, these contracting units are going to have to do quite complex estimations of how to bring in private practitioners or hospitals or arrange transport. And we haven't seen those skills actually even in the big centers, in the provinces. Those provinces are under administration. The way Lesego mentioned capitation. So how are we going to work out how much a private GP or private provider is going to be given? What population are they serving? When the hospitals, private hospitals get paid, there's something called a DRG. You might hear the term, a diagnostic related group. So what happens in other countries is hospitals get paid a blanket amount if they see so many people in this DRG, in this group of diagnoses. But it's quite complicated to work out how to allocate DRGs and how to reimburse them. And we're expecting people who've never actually worked with this before to manage this in the NHI. So it's going to be a recipe for some problems. The Development Bank South Africa did an audit of health managers with the idea of improving the skills of health managers. They did that at least 5 years ago. They identified many weaknesses. And we've seen attempts to try and train health managers, but we haven't seen the net results of improved management. Okay, we still have hospitals that have long queues, unfilled posts, run out of budget. The Department of Health is also very fond of taking the money it has and spending it on foreign experts. So the number of Americans from the Clinton Foundation and English consultants from DFID and any country that is providing development aid, department doesn't look inside South Africa at people like David. They will go to somebody outside South Africa to give them advice about the NHI. So we had an experience where the advisors to the Department of Health were from the Clinton Health Initiative. So that's a US foundation set up by Bill Clinton. Very nice, he wants to help people. But actually, the kind of advice they were giving were based on the US healthcare system. So they were advising the Department of Health. Essentially, we don't know because it was all hidden. But what transpired was that the private sector were given the opportunity to help shape the NHI. So a number of implementation structures were set up, and they were full of Hospital Association of South Africa, medical schemes, actuaries, people who basically depend on the medical scheme industry. And if they are going to shape the NHI, you will know it will look like what the medical scheme industry is like now. So that was challenged by PHM, and now that's sort of been put aside, but we don't know what the thinking is. But the point is, if the department wants to develop its own capacity internally, it can't keep looking to foreign experts to give them advice on management and leadership. There are a lot of training initiatives in South Africa claiming to develop health management, but we don't see the results. There's never been an audit of all the money that's going into that training. And as has been said, we may not need more managers, we might need better managers. Okay, not more managers, as David points out. Okay, so I'm going to talk a bit about participation and responsiveness. So the minister actually made this quote, 2013, the statement: universal health coverage, like any other health system, must be accountable for the quality of its outcome and the compassion of its care. Just think about Esidimeni. The emphasis should be on responsiveness to service users rather than on profits for shareholders. Okay, so the minister is making it quite clear that we are a public-oriented health sector. We want to put people first. We want to be responsive to the service users. So you all know that the Declaration of Alma Ata was the foundation of primary health care. It talks about health as a right. People have the right to participate. It's actually also their duty in terms of Alma Ata. The recent revision of Alma Ata in Astana, in Kazakhstan, also reaffirmed that, said that people, individuals and communities need to be empowered. And so health committees have been referred to. Health committees are the vehicles for participation in South Africa in terms of the National Health Act. So there are also, I'm going to talk briefly, there are also hospital boards. You know that hospital boards are set up for each hospital. They're supposed to have members of the community from the population that's serviced. We know that many hospital boards are not functioning, and they tend to be dominated by professionals. So the people who get onto hospital boards are usually lawyers, financial people. If there are community people on the boards, they don't really have a mandate, and they don't really have a relationship with the community, and they're not really trained. Hospital boards do have quite a lot of power. They can raise money. We've seen it with some hospitals, so they can really help with the hospital. But for instance, when Life Esidimeni happened, there was no mention of the hospital board in that context. When there are tragedies at Charlotte Maxeke, the hospital board is not mentioned. So obviously they're not functioning in a way to hold the service accountable. There are also councils. So the National Health Act says there must be a district health council, a provincial health council, and a national health council. So these councils are really advisory to the minister. They don't really have any power. And in the Western Cape, for instance, the District Health Council for Cape Town is really bringing the city and the province together. It has some members who are community members, but again, how they get there, they're not elected, they're not mandated, and they're not from health committees in the province. So it's not a structure that really represents participation. Also, the National Health Act talks about National Health Consultative Forums. Has anyone been to one? A National Health Consultative Forum? Anybody ever? Have you ever heard of them? A National Health Consultative Forum. Okay, I went to one. It was during the era of Mantu. And I can tell you it was basically a sham. I mean, it was a meeting, and there was a lot of discussion and a lot of cheering of the minister. But outside the meeting hall, there was a stand outside with the beetroot and the African potato at the time that there was denialism. I could not believe this. So essentially, the department's meant to have every year a National Health Consultative Forum. It hasn't had one for a number of years, and the one I went to was more or less a joke. But it's not real participation. If you have a national meeting and you invite some people, well, who's going and who do they represent? The National Health Summit that happened on the NHI, also, how did people get there? They just heard by word of mouth. It wasn't actually any mandated or participatory process. Okay. Are there any questions at that point? Okay. So health committees are really important vehicles for participation. Every health facility in South Africa, by law, is meant to have a health committee. The law, the National Health Act simply says who must be on it. It says there must be community members, the facility manager, and the ward councillor. It doesn't say anything about what they must do. And that is the problem, because different provinces will say, okay, you do this, and then another province will say, you do that. So there's no uniformity. Secondly, what the province says health committees can do can be quite empowering, or it can be quite disempowering. So they can actually give health committees powers to hold the service accountable, or they can simply say, well, the health committee is there to help the health service, in which case you help clean, you help manage the patients, you help solve problems. So it's not really very empowering. Catherine?
Yeah, when it comes to cleaning...
Is it on? Is it on?
Yeah, in Gauteng we had a meeting with the MEC. MEC was clarifying...
Hang on.
MEC was clarifying...
Hang on.
We had a meeting with the MEC MEC was clarifying the role of the clinic committees to say we are not supposed to be sent by the sisters or the doctors.
Yeah.
We are not supposed to be cleaning.
Yeah.
We are not supposed to be, the only thing that we're supposed to do is to be, we are not fire extinguishers
Yeah.
because they use us as fire extinguishers. When they've got problem with the patient, it's when they involved us. But when everything is smooth, then we are just a committee.
Yeah.
So the MEC called the meeting, called all the ops managers to say, this is what you are supposed to do. This, it's like, she said, if you are sending the clinic committee to the shop, which means you are sending me to the shop, because they are my representative, they are my eyes and ears. So she said we mustn't do anything else rather than being the eyes and ears of the MSF.
So that's the MEC that's strongly supporting health committees.
Yes.
You go to other provinces and you don't find MECs that are strongly supporting health committees. Hafsa, do you want to say anything about the Western Cape?
So for Western Cape, we had a lot of issues. Western Cape, of course, had a lot of issues. The majority of our health committees did not participate in the MEC's process, and we actually took decisions to have a parallel structure, or rather continue with the structure that we had. So irrespective whether she appointed whoever she appointed, we still have our structure continuing, and we do still meet with the health department. We have scheduled meetings whenever problems arise that we can't resolve locally. So we are actually continuing, and the MEC has done her appointments. Whatever she's going to do, we will do and continue on our own.
Okay, so in the Western Cape, the powers for health committees are quite weak in terms of the law, and she's sort of completely ignored that there are health committees functioning, and she's not giving the support or the authority to health committees to hold the services accountable, because that is a challenge. Yeah?
To add on,
Yeah?
and to add on, monthly, we make a report from each clinic.
Yeah.
There's a report where it's talk about the equipments that are being used, infrastructure, staffing, you know, and our recommendation. And then also then with that report for my clinic, we will combine it with all the 29 clinics that are in my in my district. Then we will make a one report also that is from the forum now, the district forum. Then we take them to the MEC's office and other ones to the MMC's office.
Okay, so you could hold the health service accountable if posts were not filled, that should be filled, that you know about.
Yes.
So, yeah.
My question is about the health committee, because where I come from in that clinic is that the committee is the staff. So now, which is a concern from my side, because people coming to me complaining about the clinic service, and then when I go to the committee, which is the staff, and then she actually is covering the other staff because they are working together. So now my question is it right that the committee, the health committee is the staff members? Shouldn't it be patients? Because when it's patients, then the patients, they are the one who has the need of the health. So they will know what is really needed and how things should be.
So what the law actually says is that the health committee consists of community members, consists of the facility manager or their designate, or the ward and the ward councillor. So it shouldn't be the staff blocking a problem. Because how can the staff, how can the health committee hold the service accountable if they are the health service? No?
Yeah, talking about the duties of health committees in our clinic. Yeah, the Act says now you must be a representative from your organization, religious or whatever community structure. Then, as Prof has elaborated about councillors, where we find it very difficult for them to attend the clinic committee's meeting. And another thing is that as we are busy with reviving, because in our area we have clinic committees that are more than 20 years they've been clinic committee, maybe they lost somewhere or somehow what are their roles and responsibilities. Luckily, we were trained with the partnership by EU City with Learning Network. So that's why last week we have a revival to review for those old health committees that are still claiming that they are health committees, but they don't do their duty. Because if we are talking about Gugulethu, you cannot say, no, we're all over. Meanwhile, there are 9 members of health committees that's supposed to do their duties in the clinic. That's why we said now, even if the government have its legislation or act that says how must be the health committees appoint, as she appoint her own health committees. Never mind we are appointed or not appointed, we are still going to be a watchdog for community. Ne? We are still going to remain as that health forum. Ne? Because our mission is that there are health committees that applied to be health committees on this new act, you understand? But we are looking at the thing of even capturing by MEC wanting health committees to do whatever she likes they must do in their health sector. But to the review of health committees that we are busy with now, you have to sign a consent form. Because you train people to be health committees and know all the roles and responsibilities and have their big CVs, go and look for work somewhere else, not wanting to serve a community anymore. Yeah? So it depends also to a community. Pointing fingers, what is happening, what are you doing with the services that are not rendered in your clinic as a community? Because everyone has a right to health. When we talk about right to health, when we are in the facility, why are you leaving your community health care center with a complaint, not knowing that there is a clinic committee or there is a facility manager or administrator? Because once you are not pleased in the health care center and there is a big ball outside the clinic that says these services are rendered to this clinic, there are social workers, there are physiotherapists, there are everything, but you will find out people pay doctors, private doctors, when they want a physio, you understand, not knowing that they are, they're in a staff, they are health promoters that are supposed to educate the community when they're gathering in that administration department, even if they are in the pharmacy, to educate even our senior citizen, what are the services that are rendered in this CHC, so that people won't go outside and go pay money. Meanwhile, the government said there are services in this clinic. That is a duty also of the health committee. In those meetings outside the clinic, when your ward councillor is calling a meeting, you ask him a slot that I want to present this, I want to say this in the meeting. I don't think he will deny you say because at the end of the day you are helping him, because in that what committee of him also he's got he sector health, you know, what is that person doing as the health health? So it works both sides. If you are said you are health related, when we see this problem and you come and you check this whole care committees, if you know his name is on the wall in Gugulethu, when there are people are not satisfied about the manner that they are said in Gugulethu, then look where is Novi and ask Novi, what are you doing in Gugulethu? You know, so that if you are said we are representative of a community, we represent really community, not representing our jackets. So sometimes the line remains on us as community. Some of the health committees, they were applied. In this new act now, they applied, a lot of them. They thought maybe when there was a box in front of the gate at a clinic at NY3, say the application and every requirements are there, everyone applies. Once they knew that there is no money, there is no reimbursement, there is no nothing, they started to say, no man, I didn't know that this is not employment. You understand? But it depends for those people that are passionate to do this. Because if you are a health committee, that being a health committee, you know what pushes you to do that. You know, what pushes you to be a health committee? Are you an act activity in your area? Are you working close with your street committees? That's very important also. You understand? Because sometimes our community, as in my street 5 years ago, this guy was positive, let me say that. Ne? Then his CD4 count was 300 and whatever. You know, when you reach that, you get a grant, then the doctor identified to him that, no, you are quite fine now. I think you just look after your health and just eat nutritious food and all that. Then he says, no, I'm used to get this 800 and odd every month. Now, the doctor's going to take out that money and what? He started drinking and do all that. In that period of time, then he died. Luckily, I attended the funeral of that guy. When somebody said, a family person, yes, this guy is, because of the day hospital, that don't care about the people and all. Then I pushes myself and said, no ways. I'm at health committee in that day hospital. Luckily, I'm staying in this street, you know. And this guy was talking this thing, Kwamfana in the smoker ship in whatever, and said, no, I must default because now the grant is going to be taken, you understand? So this whole everything of being and health activities, it's go with the education to educate your community in a street level. And also for the person that is a patient that is sick with whatever chronic illnesses, that I must look after myself. But what I'm urging here is a role and responsibility of the health committees. You've been trained. Né? Some of our health committee used to sweep. Then I will come and say, it's your time to go and monitor the clinic. Why are you sweeping? You understand? But the others, we don't know what are their roles and responsibilities. When there is no security, you want to play a security role, whatever. But once you really know that you are there to monitor the service that must be rendered to a community, you check even the time, waiting period in each and every department, then you know your story. You understand? So I think out of this NHI thing, starting from empowering a community and empowering ourselves and go out there and see that what we've learned here, we're going to spread it in the community. Coming to the question of the NHI, sorry, President. I've been not talking for a long time.
You go ahead.
Coming to the question of the NHI, no? I've attended one meeting of MEC in Lentegia Hospital. I think that was last year when he called all the doctors, Eastern Cape, I think all these 9 provinces. When he was introducing this NHI thing, and then the private doctors started to be crossed because after, when it was tea time, I said, oh, I know why they are crossed, because now it's going to affect them as private doctors. Because when you go to the private doctor, he will write down what you don't have all this medication that is supposed to give you, maybe the Moxilin and better whatever, give you a prescription. You paid 500 and all to see that private doctor, but he will still write you a prescription that you go to Clicks and buy all this medication. Now the problems lie on them. When MDC was introducing these things, they wanted to caucus one side. Can you give us 10 minutes so that we caucus? I said, no, there is most propaganda in this whole thing. You understand? That is why it will take some time really for this NHI to implement it. But it lies on us also. When we talk about education, what we are going to learn here, we go and make our community understand what is this NHI all about. Who is affected in this thing? Is our people that don't have medical aid. You know, it's raining. I'm always reluctant to catch a train, a bus when it's raining, because I've been seeing accidents in the raining days, prolonging the time of coming of the ambulance. You understand? Then you'll die. And one thing that happened when you get an accident, they check on your pockets and your back to have a medical aid so that they can call quickly, 24 hours, whatever. But if you don't have, I think that's things that we must elaborate to our community. Why is this NHI thing important so that it can be implemented? The pressure that we must put to our government also about it.
Okay.
I think that's
all right, thank you. You've raised a lot of points, a lot of hands. I just want to summarize a little bit. So now we started off talking about the different roles of health committees. Okay, they can be quite diverse, and that idea of like, don't sweep, go monitor, go hold the system accountable, resolve complaints, represent your communities quite clearly. She also got into the question of the private sector. The private sector doesn't have health committees, but they should. And I think the march by MCSJ is saying, well, actually the NHI should come, and it's actually bringing that issue that Noe is describing about you go to a private doctor and you still have to pay a lot of money. And I think she's also illustrated the difference between management and leadership, because she has spoken like a leader here today. Okay, so there's a lot of hands over here.
Can I answer his question quickly of the...
Okay, answer it, and I've got 1, 2, 3, and there was...
The clinic committees,
yeah,
it's not supposed to be somebody who's working in that clinic or in other clinics.
Yeah.
It's somebody from the community who resides in the very same area where the clinic is. And the ward committee member who is on the health sector and the councillor, they are only additional members. They are not a committee, clinic committee members.
Yeah.
They are additional members. On the ex officio is it's the ops manager.
So the only health facility person who's supposed to be on the committee is the facility manager. That's what the law says. If the facility manager can't come, they can delegate somebody else to come.
Yes.
But it's meant to be community people.
Yeah, it's meant to be community people.
Violetta?
Moni, I have a question. I want to know who is supporting those communities, groups here in South Africa. Because in Mozambique, to work with the community groups is our priority in our minister. But the big challenge is because we don't have funds, money to support those groups. They are all speaking, they are all writing very good in our documents that this is our priority. We must work with the community groups that can mobilize citizens to use our service, to reduce the risk to have sickness, something like that. But in the practice, if you don't have money to support those groups, they will never work. What happened now is, if that area have a NGO to help, to capacitate them, to be with them and to support, we'll speak about community groups.
Yeah.
But if we don't have those NGO there and work in this area, we can't speak about community groups. So if the government is not supporting those groups, nothing will happen. And another thing, when those groups they're working with this supporting for NGOs. When they start to monitor the clinic, they start to ask what is going on there, what happened. Those those providers, they start to fight with them because they're feeling like the group for outside. They are coming to ask what I'm doing. Me, I'm a doctor. I know what I'm doing. This is my area. So now we want to share my power, my place. So they started too much confused. That's why they use them to clean, to help people there outside to enter here to find me as a daughter. So they change the rule of those groups. Who are changing this sometimes are the workers who do it, and they manipulate citizens to think, okay, my job is to clean, my job is to do this. Sometimes they know the truth, but they don't want to share to help them to know what must be done really.
So I'll try and give a quick answer because the health committees here will give a long answer. So basically, you're absolutely right. If the health committees aren't supported, they can't function. People need to get transport. People need to have cell phone time to function. It's not a lot of money, but say in the Western Cape, the health department years ago provided that support through, social capital grant. Then when they withdrew it, it just happened to be that we had some donor funding to support it. But in other provinces where there's no support, it's really hard. So unless in Gauteng, where there is support from the MEC or for the province or the municipality, it's really hard. So there's that, on the one hand, people say this is the policy, they talk nicely, they write nicely, but they don't provide the resources. So it's absolutely important. That's part of our campaign, that health committees must have resources to function. Yeah?
Thank you very much. I'm very happy that people, they are sharing their challenges, our challenges that we're experiencing in the community. As Noe, and also she mentioned that people, they get tired and end up lose focus. Therefore, it need us as a leader that we are here to make sure that we work really as a team, very flexible, and also I'll ask the team that is manager this training to make sure they support us with ongoing trainings and ongoing evaluation so that we don't lose focus on what we're supposed to do. And again, I know that when you go in the community, you end up get frustrated because of many major and critical things that are happening in the community and end up losing focus on the main point, NHI. And then that will require many trainings, many team meetings, and also and working together. And as a leaders, because after this training, I don't think that will get the managers, but will stick to be leaders. And therefore, we know the challenges and we need to be creative around the situation that will be going to be faced. And that will need the teamwork. This meeting from yesterday to today, it reminds me 2004, the time that I was working for Desmond Tutu, and with the bridge between the scientists and the community. We're working very close with HBTN and MRC to have strong principles and values and following the ethics and make sure that you are giving the people the right information. It's strengthening us and also strengthening the community so that at the end of the day we get the good results. Because the HIV vaccine, it was the most critical education where people, they were going to be put the particle of the vaccine on their body in order to check their antibodies is working. And people, they were scared of being guinea pigs then. But good education surprised the science people. When the trials were going to start, we were looking only 50 people for the phase 1. But 100,000 were ready to come for the vaccine. And the scientists were asking, these people, they want to be a part of the trials, but good 3 years education prepared the community so well, and numbers of people were coming to join the trials. And therefore, if we stick to our principles and values, in 3 years' time, we'll have good results on A. Especially if we're giving people a good education and we stick to our principles and values and we don't lose focus. Thank you.
Okay, so you've made a case, a very strong case for power of education. I'm just going to try and open that blind up there if we can get some more light, if it's working. Please go ahead. That's good. I think it's not working, actually. Well, let's just finish here. We're almost done. Okay.
Yeah, okay. Too many challenges now, the light and hearing. But I want to ask a question from maybe Norway and the other comrades there. Is there a difference between a clinic committee and a health committee? And then secondly, is there a legislation or an act that provides the guidelines of the work of the health committee or the clinic committee? And then how are they? Sometimes you just see, as Noe is saying, you see the names of the people, but you don't know how were they appointed, were they elected, and how, and all those things. Yeah.
Good questions. Who wants to answer? Start with Navi. Oh. You wanted to ask a question, yeah?
Okay. Clinic committee and health committee. Here in Western Cape, I understand they call them health committees, if I'm not wrong there. In other areas, they call them health committees. In Gauteng, we are called clinic committees, specific clinic committees. And then we are nominated by the community to serve in the interest of them. Especially like now, there are new forms. It's not just a clinic committee, it's for ideal clinics. Then we are nominated, we nominate 8 people. It depends with your clinic. Some we are 5, some clinics are 8. Then we are nominated. And the process goes to the MEC's office and he appoints us and sends the appointment letters. But definitely there's no remuneration or anything. We are the Fish family. In our meetings, we drink water. And nobody's paying us for being in the clinic the whole day, the rest of the week.
Is there a legislation or an act?
Yes, there is. There is. It's legislated. The clinic committees are legislated. That's why now we are busy fighting with the MECs, because each and every MECs that comes in will say, no, I'll do things better. I will be paying you. For instance, Papo was the MEC, the latest MECs. Papo says, no, Dani didn't do her work, then I will be paying you. I'll give you 2.5. Then when it's supposed to that to be done, such izinto, Dani came back and it was quiet. Now we are busy with Gwen, and Gwen now is going out, but she still promises us to say, I'm gonna make sure that I'm taking funds from somewhere and reimburse you. And that was supposed to be started last year, September.
So a lot of promises. So the National Health Act is the act which says there must be health committees, but it doesn't say,
Can I add on what?
She wants to, can I just finish? So
yeah, but clinic committee, I'm just going to.
I'll let you finish that. The National Health Act says.
Clinic committees.
The National Health Act is the act which says there should be clinic committees. And it just says how they're constructed, but it doesn't say what they should do. It says the provinces must legislate what they must do. Okay, so each province has a different idea of what they must do. The National Health Department has a guideline that they brought out, which actually gives clinic committees quite strong powers. But if you go to the different provinces, it's all different. So some provinces talk about payment, other provinces no talk about payment. Some provinces talk that they can be involved in accountability. Other provinces, it's really helping the clinic. So that's the problem.
To elaborate more about what is clinic committee and health forum. Clinic committees are those that are based in clinic, that are monitoring the services based in clinic. If forum, health forum, as we are health forum, we are coming from different structures that forms that forum and monitor the health committees that is doing what they're supposed to do. Clinic committees are those that are appointed now, but they are not functional now unless they get induction and all that. But those that applies as clinic committees that are in health forum, that are going to work with hand in hand with MEC, that are in the forum now, they are going to be health committees, those that applied for this act and the legislation of MEC. How forum was made, it was made of different, like Usi's Choice was coming from the anti-eviction campaign that were used to come and block a clinic and said, who's working here? We're going to close this gate. We don't want to see you. Then we said, no, there is a forum here. You cannot just come and close the gate. If you are a representative of different organization, come have a mandated letter from your organization that you're going to join the forum. So the health forum that is there consists of different, I was coming from the civic structure. As you know, we being in a civic organization, that with the HOD of health, then automatically I'm coming from organization, I represent the area. That's why we call now health. Even those people are going to be clinic committee, we're still going to remain as a forum, monitoring them that are doing what they're supposed to do in the clinic because they are clinic committee.
So the forum also deals with issues outside of the facility, so broader issues. Okay, you've been very patient.
Clinic committee.
Okay, can we have one conversation?
No.
Can we have one conversation here? So, got the mic.
Ezinye zilashile ke ngoku because benifuna uba related kule message kaSiya. In Tolbach there is no NGOs.
Okay.
People there, it's like a rural, the poor rural area, the one who don't get ambulance, everything, the one, I don't know how can I explain that.
Yeah.
Because it's in the dark.
Yeah.
So there is no NGOs. Even now we are struggling to make TAC branch there. Because people on Tolbach, they believe if they wake up in the morning and go to work and come back, they don't care about everything.
Yeah.
The problem, what is causing that problem is political parties. The DA is ruling there, and they do what they want to do. So people are tired. Even now, there is fixed dose combination. But they give some, not all of them, they give that fixed dose combination. Some they still eating that 7 tablets, others they eat 3. So it's not good at all. It's not good at all. I'm trying to fight, but the clinic committees, who are the members, who are the staff, they don't want TAC there. Because they say TAC is going to take their jobs. No, it's not like that. They're going to.
So what you describe is actually some experience that many health committees have had when they started, when the health service didn't like to be accountable.
Yes.
So maybe in the break we can have a discussion, because we are running very late, that you could talk to the other clinic committee members and find out how they went about organizing.
Yes.
But the law is clear. You cannot have a health committee made up of the health professionals from the clinic. That's not a health committee. That is something they've created.
Even
the law
the
is absolutely
hospital,
clear.
If they don't know you,
Yeah.
and they don't recognize your family, you will die in a chair. They don't even give a care for you.
Yeah.
You will stay in the chair for as long as they want.
Yeah.
You can stay the whole week without attending you because they don't know you.
Okay.
They don't recognize your family. But if you are a rich family and someone of your family is working in the hospital, they take care of you. Immediately you come in. But others, no, they don't.
So that is the job of a health committee, to monitor the service and raise the problems. And you have the law to say that that is what you're supposed to do. Sis Nayu will talk at length about it afterwards. Okay, but not now. Okay, because we have to move on. Okay.
Thank you.
Can I just say one thing?
If you want to say something, you have to use the microphone.
I do agree with Norwie. Your clinic committee and your health committee are two different entities, because your clinic committee will just operate from the clinic and look at problems that are happening at the clinic. Your health committee or health forum have been doing that, plus what I actually want to say is they are basically looking after the wellness of the community, because we are an entity that have representatives on your CPF, your neighborhood watches, your ECD forums, any other structure that would result in people coming to your healthcare facility. So anybody that might end up at your healthcare facility, that is where we have representatives. So people coming to your healthcare facilities, not just people who are your chronic patients, you also get crime that results in people coming to your healthcare facility. You have something happening at your ECD. So we make sure that outreaches go to your ECDs. We make sure that whatever happens at the police station, that we know what is happening there, why people are coming to. So we really look after the complete wellness of a community. The one thing I also want to say is when I came here yesterday, I actually had a question for myself. What will the role be of health forums or health committees regarding NHI? That was my question. And I thought to myself, maybe if NHI is the solution to the current health crisis that we have in our health system, our role will be less or diminished, or we might not even have a reason to be there. But let me tell you, after hearing everything today and yesterday, I think we will need to be there even more, because there's going to be a lot of contracts and whatever involved. There's a lot of chances for capturing. There's a lot of opportunities for things to go so wrong. Especially with this, if we don't do this properly, there's going to be, if we don't do this properly, there's going to be lots of problems in the future. So from community representatives, can we just go out to our communities, make sure they get the information, make sure that when we do lobby to government that we get what we want and not what government wants to put down our throats once again, because health committees got a raw deal, especially in the Western Cape, we got a raw deal. We don't have the support. We need to make sure that this time government gives us what we need and what we want.
Okay, so on that note, so the National Health Bill is completely silent about health committees. Doesn't say a word about, it just says there will be health committees. It doesn't give them any powers in particular. And a lot of the structures of the National Health Insurance are very important structures with no participation from communities. So the Benefits Advisory Committee, which is going to decide what benefits the National Health Insurance will provide. There's no health committees, no popular, it's technical people, it's epidemiologists, economists, actuaries. So that is a problem, and that's exactly what Hafsa is saying. If there isn't a strong community voice making sure the services are accountable, it can go any which way. Sina Sipo.
Just a comment, Lacey. We don't have to answer this question, but I think it ties in with the concern that everybody has in the room, whether they're health committees or whatever leadership structure, because it's very clear that the NHI is going to have to come with a particular leadership structure, but it's coming into an already existing leadership, an already existing structure, and how are we going to match the two? So, for example, in Western Cape, we have national, but we have provincial. We know who are in charge of particular things in the province, but we also have local government. Then we also have them being in charge of particular things. So when the national insurance comes in with their leadership structure, are we working to match that? Who's going to be displaced? Who's going to be, you're going to wake up one day, you're going to have a job, or you're not going to have a job if you've been in the current if you've been in the current leadership structure. And I think there's just a little bit of apprehension of what is going to happen in terms of just leadership and management when the NHI comes in. Yeah. What the NHI is proposing is it's coming into an already existing leadership structure. Will it wipe out completely what already exists and bring in something new? Or are we going to incorporate what is already existing into the NHI?
So let's just remember the NHI is a way to finance healthcare. It's not a way to provide healthcare. So the health departments will continue to exist. But what Sinisipho is pointing out is there's confusion because the NHI bill doesn't really establish how this NHI funding mechanism is going to work with the provincial health department and the local authority health department and all those things. So that's a concern. I want to try and move us on. Can you hold that? Is it urgent? Can you hold it? So just to summarize from the management and leadership, what PHM is saying, we need to have leaders and managers appointed on the basis of skills, that the skills they need to be appropriate to ensuring the system is accountable and responsive to people. And if they don't have that skills, the managers need to go for training. We need to keep the private sector out of the decision making because the private sector will try and make decisions to influence their benefit. A human resource plan that is implemented. So we've had many human resource plans that never get implemented. Our leaders and managers need to be accountable. Doesn't mean that we have to bash them, but they need to own up if there are problems and be accountable. We have to have a management system that rewards good managers. Because sometimes there are good managers and they don't get rewarded or they don't get rewarded for innovating something. And we need to have less managers and more appropriately skilled managers. And we need to strengthen bottoms-up accountability. So there isn't really time to talk in any detail about financing, but I just want to make some points. Firstly, how much money is given to health? So in South Africa, we spend about 8.3% of GDP on health. It's pretty low compared to other countries. Some years ago, African countries got together and said we should spend 15% of our budget on health, and we're at 8%, so we're quite far off the mark. So we can argue we need to spend more on health, but we also need to spend what we're spending on health better, in a better way. So both of those things apply. What we spend on health is not properly distributed. So we've heard for rural areas, it's a problem. Can't get an ambulance, the infrastructure is poor, so there's an inequality from urban and rural. There's the problem we've discussed at length between private and public. There's also the problem, as David explained, between hospital care and prevention, between curative care and health promotion. So we spend much more on hospitals and curative care. And the reimbursement systems, if we do bring in the private sector, so capitation, for example, it means you pay a flat rate for the whole community. That is a much better way of paying rather than fee for service, because if you pay a private provider every time for a service, they will provide more services than you really need, and you end up paying a lot. So those are problems for financing. The consequence of that is one of the problems we spoke about yesterday, is that the hospitals and the facilities that will get accredited for the NHI are the ones that will have already more resources. So the rural hospitals, the semi-urban, the peri-urban townships will struggle to get accreditation because they're already in very poor shape. So it will just aggravate inequality, and that's what we have to guard against. The Hector from Section 27 spoke about a quality improvement plan, which is recent, which might improve the public sector hospitals, but we haven't seen that in practice. The medical aid, the tax deduction, the subsidies, there were 2 points made, and Lydia sent these figures that, in fact, the amount of medical aid that is paid back as a tax deduction is 16 billion rand. So in other words, people are not having to pay in 16 billion rands worth of tax because of the subsidy. So that's a loss to the budget, to the fiscus. So the state doesn't have that 16 billion rand to spend on health or education or housing. And then the direct subsidy to people who work for government is 20 billion. So teachers, nurses, doctors, anyone working for the public sector, government pays for their medical aid 20 billion out of the tax. So that's a lot of money. It's not going to fund the entire NHI, but the point is there's a lot of money that's being lost in this whole medical scheme system. Yeah.
When you say government is...
Where's that?
So is this for the GEMS?
GEMS. Well, usually GEMS or Bonita, so I don't know whatever the schemes are.
I'm not quite clear, so I just want to clarify. Is it that there is like a medical aid for those people, or is it that government is paying for them to go to public facilities?
No, it's a medical aid. So many public sector workers have medical aid because they're part of the public sector. And the government is the employer then and pays its portion as an employer.
So they don't encourage them to go to public facilities. They give them a medical aid to go to a private person.
Yeah, yeah. It's one of the biggest medical aids in the country, and in fact, the department seems to think it can build the NHI on the back of GEMS by sort of gradually expanding it, which is a problem. Okay.
It means we should encourage them to switch from private to come to them.
So the way to encourage them is to have services that are good quality.
Okay.
Because then they won't have to pay huge medical scheme contributions. Yeah.
I mean, I think there's also
When.
there's also probably a need for some kind of research to look at how is it that our employment became tied to medical aid schemes, because I don't think this happens everywhere in the world. It's quite unique to South Africa and probably certain parts of.
So if I understand it, there were changes to the Medical Schemes Act under the apartheid government, and the apartheid government's vision was that government employees would be taken care of in the private sector. And it was actually deliberate. It was encouraged. So it has a historical background, but I'm not an expert in that field, so you're right. Okay, so what PHM is proposing about the finances, so that this, the medical scheme tax should be gradually done away with. It can't be done away with overnight because there are a lot of workers who are basically going to be affected. So it needs to be phased out, and at the same time, the quality of public sector facilities needs to be improved so that people will say, okay, I'll go to that. Secondly, we need an increase in health expenditure, which needs to be funded from tax. So we have people claim we have high rates of tax, but we don't have high rates of tax compared to other countries. The amount of tax to GDP, if you compare the ratio, is actually quite low. And the state has been keeping it at a fixed level, whereas other countries actually let the tax compared to GDP ratio go up much higher. So we're saying that it should be allowed to go up higher, and that way you get more funding from tax. And what you get should promote prevention, primary care, promotive health care, rather than tertiary care. We're supporting the idea of preferential admission of students from rural areas to health facilities, and career opportunities in rural areas, and upgrading education and infrastructure. And then supporting the primary healthcare re-engineering, the ward-based outreach teams, because we think that is a good model, but it needs to be properly resourced. So that is what I was going to cover, more or less, and we're way over time. Okay, take one more question.
I just want to know, with regards to the NHI or looking currently at the current public sector and how it's worked out, in order for you to go into, and many patients really do need tertiary treatment, non-emergency treatments, you know, you need to get a referral, and usually your referrals then come from your GPs, which are private GPs. How are we trying to rid, because that really, it places a lot of financial burden on individuals to actually then, in order for them to access even the tertiary hospitals, to go through these private GPs. How are we trying to eradicate this? What is our thought behind that? Just
Well, the NHI will say that to go up the system, you need a referral. And who the provider is doesn't matter, whether it's a GP or a community health center or a medical officer working in a district hospital. And it should all be the same. So there shouldn't be a provision of who refers you, but the quality of care needs to be provided. And obviously, if we have a strong primary healthcare system, people who need care should be referred up. So it might even increase the number of patients coming up. But if you have good prevention, it should reduce the number of patients presenting in the first place. So the thinking is basically a well-functioning system will have a well-functioning referral. Well.